Hi, this video is about urolithiasis, commonly known as kidney stones. Kidney stones are hard deposits of minerals and acid salts that stick together in concentrated urine. They can be painful when passing through the urinary tract, but usually don't cause permanent damage. Concrement-forming substances such as calcium from intestinal absorption in the face of elevated calcitriol, phosphate from metabolization of bone in the face of elevated parathyroid hormone, as well as uric acid, xanthine, and oxalate from intestinal absorption and disordered metabolism in the liver, can reach concentrations in the urine that lie above their solubility threshold or the ability for them to dissolve. In the so-called metastable range of these substances, the formation of crystals may not occur at all or only slowly despite the supersaturation of the solution. However, when the concentrations rise beyond the metastable range, crystallization occurs. Dissolving already formed crystals is possible only by reducing the concentration to below the metastable range. The most frequently found substances in the kidney stones are calcium oxalate in about 70%, calcium phosphate or magnesium ammonium phosphate making up about 30%, uric acid or urate making up about 30%, as well as xanthine or cysteine in less than 5% of the crystal. Several substances may be contained in one stone. This is because crystals that have already formed act as nuclei for crystallization and therefore facilitate deposition of other metastably dissolved substances in order to make up the total concentration of the crystal. Certain substances that form complexes such as citrate, pyrophosphate, and acid phosphate can bind calcium ion, and by reducing the calcium concentration are able to prevent calcium phosphate and calcium oxalate from precipitating. So what causes stone formation? Well, the raised concentration of stone-forming substances can be the result of pre-renal, renal, and post-renal factors. Pre-renal causes produce the increased filtration and excretion of stone-producing substances via a raised plasma concentration. Thus, pre-renal hypercalciuria and phosphaturia are the result of raised intestinal absorption or metabolization from bone, for example, if there is an excess of parathyroid hormone or calcitriol. Hyperoxalemia or elevated oxalate can be brought about by a metabolic defect in amino acid breakdown or by increased intestinal absorption. Hyperuricemia or elevated uric acid occurs as a result of an excessive supply, increased new synthesis, or increased breakdown of purines. Xanthine stones may occur when the formation of purines is greatly increased and the breakdown of xanthines to uric acid is inhibited. However, xanthine is much more soluble than uric acid, and xanthine stones are therefore much less common. Abnormal renal reabsorption is a frequent cause of increased renal excretion in hypercalciuria and an invariable cause in cystinuria. The calcium concentration in blood is then maintained by the intestinal absorption and mobilization of bone minerals, while the cysteine concentration is maintained by reduced breakdown. Release of antidiuretic hormone in volume depletion or hypovolemia, as well as in stress, induces an action on the aquaporin channels of the nephron, causing increased reabsorption of water. This leads to a raised concentration of stone-forming substances via enhanced urine concentration. The solubility of some substances depends on the pH of urine. Phosphates are easily dissolved in an acidic urine but poorly dissolved in an alkaline urine. Now, phosphate stones are therefore, as a rule, only found in alkaline urine. Conversely, uric acid or urate is more soluble when dissociated than undissociated, and uric acid stones are formed more readily in acidic urine. If the formation of ammonia is reduced, the urine has to be more acidic for acid to be eliminated, and this promotes the formation of urate stones. A significant factor is also how long crystals that have already formed actually remain in the supersaturated urine. The length of time depends on diuresis or the urine passage and the flow conditions in the lower urinary tract that can, for example, lead to crystals getting blocked. This indicates the post-renal cause of kidney stones. The effect of urolithiasis is that it blocks the lower urinary tract. In addition, stretching of the ureteric muscles elicits very painful contractions known as renal colic. Obstruction to flow leads to ureteral dilation and hydronephrosis with cessation of urine excretion. Even after removal of a stone, damage to kidney may persist. The urinary obstruction also promotes growth of pathogens leading to urinary tract infection or pyelonephritis. Urea splitting pathogens from ammonia found in urea causes alkalinizing of the urine. This in turn, in a vicious circle, favors the formation of phosphate stones. Now, even without bacterial colonization, intrarenal deposition of uric acid in the case of gouty kidney or of calcium stones in the case of nephrocalcinosis can result in inflammation and destruction of the renal tissue. Thanks for watching. Please like this video and subscribe to the channel. More videos coming up. See you in the next one.